Hi, I am Dr. Bhaskar Shenoy, Head of the Department of Pediatrics at Manipal Hospital, Bangalore. I am also the Chief of Infectious Disease Division in the Department of Pediatrics. Going to talk about COVID-19 in children. This is the topic which has been hotly debated, and with the prediction of new third wave in the coming months, this becomes a more important thing. All these days, we have never given much importance to COVID in children because it was supposed to be very mild and very less frequent in children. But now with the prediction of a third wave, and with the third wave affecting more of children, it becomes more an important issue. So today I am going to talk about the background, the epidemiology, clinical features, how do we assess the severity, how do we make a diagnosis, what are the options left us for making a confirmed diagnosis, the management issues, neonatal COVID, then MISC, and then some key messages. So we know that COVID in India currently is at the peak, and compared to the December, January, etc., now it is in the highest thing. Daily new cases are in each state, it is in 20,000 to 30,000s with quite high death rates. The statistics are more scary when you look at the global and our own country, and even our own states like Karnataka, Maharashtra, Delhi are seeing a lot of, West Bengal also, lot of cases. So with that, the current status is that if you look at the age group, the 12% of the cases, they constitute below, less than 12%, below 20 years of age. And if you look at the death rates, the total of deaths, less than 3% occur in people below 20 years. So that means the overall incidence of the infection in the below 20-year age group is very less, and overall death rates compared to the total death rate across the globe is also very less. So the common age group in pediatrics is more of a older age group than very younger age group. If you look at here, the 11 to 20 years constitute around 8%, whereas 0 to 10 years, it constitutes about only 3%. So are children more frequently affected in the current surge? That is one. Because all of you as pediatricians and in your daily practice, you would have seen more of positive cases from children. In the first wave, we never had a lot of positive children, but in the current wave, we are seeing more of positive children and more children coming with some symptoms. Thankfully, it is not very severe, and we are seeing different types of symptoms also. So absolute numbers have increased proportionate to increase in the number of cases. The absolute number has increased. The proportion of individuals, as I told, the confirmed case has been consistently below 12%, as it's been in the previous surge. So the second wave and the children, if you look at, definitely there is increased number of infections. That may be because of the lowering of the guard. Once the first wave went off, then people started mixing functions, playing together, less importance to masks and social distancing and sanitization. So that led to lowering of the guard, and that has probably been responsible for increased numbers. The children started going out, and there is an increase in the number of cases in the adults, and through the adults, these children might have got. And as I told, the adherence to SMS means social distancing, masking, and sanitization. These three important, the so-called social vaccines, are very important in prevention of these infections. And now it is said that the current wave is more of a variant because of the variant virus, and that is supposed to be more infectious. And once it comes, the incubation period is also less and highly infectious The second thing is the entire household is affected. So there is no way the child can escape. The child also gets infected from the infected adults. There is a bit of increased severity of infections, and we have seen more number of children coming with fever and gastrointestinal symptoms. It can be abdominal pain, it can be vomiting, it can be loose motions. And some of the children come with the prolonged period fever. Though in children, the fever doesn't last for a long time. Generally 2 to 3 days or 1 to 2 days also, the fever disappears. But in some children, it can be prolonged. And when it is prolonged, we need to look at other alternative diagnosis rather than just looking at COVID-19. And complications like COVID pneumonia and hypoxia are not very common in children. We have not seen many children, but in adolescents, occasional here and there some cases have been reported. And now the other thing is that MISA, multi-system inflammatory syndrome of children, has started appearing again. Some of the centers have started reporting more and more cases of MISA. However, overall, in spite of these things, the disease in children is still milder than adults. And it is only around 1% of the children need hospitalization. So having said that, why are children less frequently or less severely affected than the adults? So as we know, these they are less susceptible to infection by COVID virus, that could be SARS-CoV-1, MERS-CoV and others, as compared to other respiratory viruses. Most of them are spread from infected adults. As it is from the children, it is not very common. And isolation of individuals with the SARS-CoV-2 infection may reduce the exposure to children. So it is important that we isolate the adult members of the family so that the child doesn't get into the infection. And among the various studies of household contacts, odds of infection in children were significantly less than elderly. So the other reason is that the expression of primary target receptor for SARS-CoV, that is that angiotensin converting enzyme 2, has not matured. It matures only with age. And this particular enzyme has lung protective effects by limiting the angiotensin 2 mediated pulmonary capillary leak and inflammation. So less of attachment to the respiratory mucosa because of the less of the receptor for SARS-CoV, that is ACE2 receptor, may be one of the reasons why it is not very common in children. Then children have a strong innate immune response, that is what is called as a trained immunity. We have trained the immune system of the children by giving more vaccines. The present generation children have taken many live vaccines and they have suffered many frequent viral infections, and that probably would have trained the immune system. So the innate immunity is much stronger in children compared to the adults. And if you look at the previous wave, the more of older age group and those with the comorbidities suffered. That is probably because there is what is called the immune senescence. The immune system is not mature enough or strong enough to handle that. So these children who have been immunized and has trained immunity, they have early control of infection at the site of entry. And as I told, adults have less, suppressed adaptive immunity. And children have excellent regeneration capacity of alveolar epithelium. The alveolar epithelium has a very good regenerative capacity that may be responsible for early recovery from COVID-19. And children do not have comorbidities like smoking, diabetes, hypertension, etc. So these are probably reasons why children are less frequently affected. And if you look at the effects that children has, the COVID-19 has on children, it can be classified as a direct effects and indirect effects. Direct effects we are able to see acutely. One is the respiratory infection, could be upper or lower infection, or GI infection. Sometimes they come with the neurological symptoms also. MISC, temporarily associated with the COVID-19, is also seen. And some of them come with atypical presentations, not the typical described presentations. There is also indirect effects of the COVID-19 in children. One is because of this closure of regular schools and less of playing, and then learning is affected. Many children have come with mental health issues. It can be hidden. They may have a mild amount of anxiety. They come with psychosomatic issues, chest pain, headache, all those things. And the nutrition also gets affected. And the other effect is the obesity, because they don't have an option to go out and play. They don't have the regular physical exercises, and always gluing on to the TV and eating all unhealthy foods might have contributed to more of obesity in these children. So these are indirect effects of COVID. Now looking at the mode of transmission, as we know, the respiratory virus can be transmitted by contact, droplet, or airborne. Now initially they were telling that last year when it first started, contact and droplet transmissions are more important, but now even airborne transmission also has been implicated in the transmission. So large respiratory droplets, they have reducing the direct contact by cleaning the surface, or physical barriers, physical distancing, or by wearing high grade protection, or for aerosol generating procedures, we can reduce it. So measures to avoid inhalation of infectious aerosols by ventilation, air filtration, use of masks, and quality of mask is also very important. The fitting of the mask is also important, and especially the healthcare workers and the frontline workers are very important that we prevent the infection by these routes. Most important thing is the diagnostics. So how do we do the diagnostics in COVID? So first we should know who are the suspects, COVID-19 suspects. When do you suspect? When do you do the test? The commonest cause of acute illness in children, acute febrile illness in children, you have to suspect. Because these symptoms are non-specific and they are like any other viral illness. These infections, these symptoms may always be overlapping, looking like other viral infections. History of contact may be there, may not be there. Children may come with fever, sore throat, cough, breathlessness separately or in combination. Loss of smell and taste is not very common in children, unlike adults, but some of the adolescents around 14-15 years, they have come with these symptoms. And a very small infant comes with poor feeding. Abdominal symptoms, as I told, diarrhea, vomiting, abdominal pain. There may be some dermatological manifestation. They may come with rash, or some children may come with the shock, drowsiness, etc. The number is very small, but they can present with, especially with the MISC. And those who are asymptomatic contacts of a COVID-19 patients. That means there is a COVID-19 positive patient at home, and this child has come in contact with. So, or there is a asymptomatic person with whom this child has come into contact. So, these are the situations where we think of COVID-19 suspect. And testing, whom to test. So, ideally, all where we suspect COVID-19. The history of contact, all those things, whichever I told, whenever it is there, we have to do the testing. But if you keep on doing the test, it is said that the prolonged turnaround time, the number of samples will be more, the workload on the labs will be more. So asymptomatic contacts and children with mild symptoms, no comorbidities and known contact, but these cases, you can defer the test. comorbidities of significance, those who have neurological disorders, those who have chronic lung disorder, those who have liver disorders, those who have cardiac problems and diabetes, all these have a higher risk of severe disease. And morbid obesity is one of the things. Immune deficiency or immune suppressive states like malignancy or malignancy treatment, child with a severe malnutrition, and all other immunocompromised states, we have to do the testing. So what are the tests that is available? Ideally, the gold standard is RT-PCR, which is being done routinely everywhere. But the turnover time is more, at least 24 hours it takes, because it has to be pooled, and generally if the load is less, they will do very early. Otherwise, when the number of samples is more, it may take even 24 hours. In a peak season, 2 days, 3 days also have taken. But for the immediate diagnosis, CBNAT is also like how we do in tuberculosis gene expert. The Cepheid has done CBNAT test also and TrueNAT test. These give immediate reports, and in these cases, there is no need to pool the samples. Even one patient comes, immediately you can give the report. The CRISPR and loop mediated isothermal amplification LAMP are also done. But the first two things, that is RT-PCR, is most important, and CBNAT also can be done. Antigen is one of the very easiest method, easiest in the sense it gives report within no time. It is a point of care test, and it can be done individually on the patient. And especially if it is positive, it means the child is, if it is negative, doesn't rule out COVID, then we have to confirm it by PCR-PCR. Antibody detection is not for acute cases, but those, because as you know, antibody development takes a few weeks. So the antibody detection is done for especially those patients who are suspect MISC and related syndromes, or those where you want to document that child had previous infection. In those cases, we can do the antibody test. The specimen which is used is generally nasopharyngeal and oropharyngeal. Ideally, both nasopharyngeal and oropharyngeal swabs are taken. That is the best way. Whenever you have a interventional pulmonology procedures like BAL, you can get it. But doing a BAL in this pandemic generally is very less. Sputum can be given. Sputum is supposed to be the sample. So comparatively, compared to the upper respiratory sample, the lower respiratory samples are much better. But getting a lower respiratory sample is very difficult. Saliva has been tried as a means of this thing, wherein you need not go through the swabbing and other discomfort causing methods. Some countries have been tried, but it is not very generalized or popular. Swab, which is quick and specificity. It is a point of care test in ER settings. And positive, if it is positive, you need not confirm with the RT-PCR. Only the negative you have to confirm. The RT-PCR again doesn't correlate with the severity of disease, the CT value. Most of the RT-PCR reports, if you see, you have what is called as a CT value. CT value means cycle threshold value. The cycle threshold value is to get the PCA RNA, how much we have to, how much number of cycles it has to give a positive report. So if the infectious load is high, the CT value will be less, but the infectiousness or the transmission capacity is more. So more the number of CT value, that means the sample has to go more number of cycles. This more the number of CT value, more number of cycles, the amount of virus load is less, infectiousness is less. Lesser the CT value, high viral load and infectiousness is more. That indicates interpretation of CT value. But it doesn't correlate with the severity of the disease, because most of the patients, they come to us telling that, sir, the CT value is quite high, we are very scared. But it is our duty to convince them that it doesn't correlate with the severity of the disease. And it again depends on a lot how the sample is collected. Antibodies, as I told, only in MASA, and always a positive test has to be interpreted in the context of clinical setting. So diagnostic algorithm, if you see, the suspect, you do the antigen test in the nasopharyngeal swab. If it is positive, the COVID is confirmed. If it is negative, you should do a RT-PCR. And if it RT-PCR positive, again COVID is confirmed. But if the RT-PCR is negative, you have to rule out other illnesses. And after 2-3 days or 3-4 days, you have to repeat the RT-PCR if it is available, plus if there is a strong clinical suspicion. And you may have to do antibody test, CT scan if protracted symptoms, and then treat it as a probable COVID-19 unless an alternate report is available. Now, role of a CT chest in children with COVID-19. Most of the parents would have heard that CT is being done for all the adult COVID. So they demand that we should do a CT for a child. So absolutely there is no role for routine CT. Then when we have to do CT, CT is in fact more sensitive than the chest X-ray. But the problem is that it is costly. It needs a sedation, especially younger children, and there is a risk of radius exposure. And CT chest is not indicated in mild disease, and prolonged fever, it can be done unless lower respiratory tract involvement is suspected, and moderate or severe disease with positive RT-PCR, wherein to assess the severity of the disease, it is not done. So it is indicated in suspects who have protracted symptoms but negative RT-PCR. For example, you have done the RT-PCR, RT-PCR is negative, but the child has symptoms, and clinically there is a strong suspicion that it could be COVID-19. So RT-PCR negative itself doesn't rule out, you may have to repeat it, but meantime get a CT to have a corroborative evidences of involvement of COVID-19 on the lungs. Sick child, acutely sick child who is breathless, and you don't have any alternative diagnosis, there you have to do. And a COVID-19 you have admitted, but he deteriorates. To determine whether there is a what is the grade of involvement of the lung, you may have to do a CT test. These are the few pictures of CT, the ground glass appearance, and more affection in the peripheries. That is classical finding in COVID-19. The peripheral involvement, ground glass, and various other things like honeycomb appearance or pneumonias, whiteout lung. So any of the other features may be seen on CT, but it is very uncommon, not very common in pediatric COVID. And this is one wherein you can see the early changes where bilateral changes are there. And more, as I told, it's peripheral changes, and these are ground glass opacities. And there is what is called as a halo sign. Halo sign also indicates that it is a more in favor of COVID-19. Having said that, let us talk about the clinical features of COVID-19. So the incubation period is, on an average, it's 5 days, but it may be 2 to 14 days, which is similar to adult. So median incubation period is 4 to 5 days, but it can be 2 to 14 days. And we need to know, once the incubation occurs, how the progression occurs. The staging, the early infection, this is the stage 1, the stage 2, pulmonary stage, the stage 3 is hyperinflammation stage. So what is happening is that once the virus gains entry in the early infection, it increases, and that is the viral phase. Whereas the next, when the viral phase starts coming down, the inflammatory phase goes, and that increases, and that is responsible for most of the complications which are seen in these children or COVID patients. The clinical symptoms in early phase, it can be mild constitutional, fever may be there, diarrhea, headache, cough, and lymphopenia, prothrombin time may be increased, D-dimer may be mildly increased, LDH may be mildly increased. Whereas the pulmonary phase, they develop shortness of breath with the hypoxia, with the oxygen saturation being less. And imaging may show abnormality, liver involvement may be seen. And in the hyperinflammation states, we see all the severe complications like ARDS, SIRS, then shock, cardiac failure. And in this stage, that you see markedly elevated inflammatory markers like CRP, LDH, IL-6, D-dimer, ferritin, troponin, and especially when there is a cardiac involvement, NT-proBNP also may be elevated. Therapies, we have to reduce the immune suppression, that we will discuss little later. Now, the clinical phenotypes of COVID-19 in children are classified into 4 types. One is the pre-symptomatic, asymptomatic, classical manifestation, and atypical symptom. In the pre-symptomatic, which is between the exposure and the development of symptoms, and the child will be infectious during this phase. Asymptomatic, the test is positive, but he doesn't have any symptoms, even if you do for some reason just X-ray, which is normal. And these asymptomatic cases are generally identified during contact tracing, and they are also infectious. The third phase type is classical, wherein you get all these symptoms like fever, cough, cold, shortness, breath, and sore throat. Then there are few cases who have atypical symptoms. So what are those atypical symptoms? One is the gastrointestinal symptoms, which may be seen around 10% of the cases. They may be associated with the respiratory symptoms or may not be associated with the respiratory symptoms. And the diarrhea, vomiting, abdominal pain may be there. Then the cutaneous manifestations, the maculopapular, urticarial, vesicular, and livedo-reticularis can be seen. There is a typical feature which is seen during COVID is called as COVID toes, wherein reddish purple nodules on the distal digits. You can see here reddish purple nodules, predominantly in children and adults and young adults. And MISC is the other atypical manifestation. So when the disease was widespread in Spain, they started seeing more of the dermatological manifestation, and these dermatological manifestations are being seen in other countries and other part of the continent also in more and more numbers, and we are more aware that they can give urticarial rashes also, and papular rashes and vesicles also may be seen. Now coming to the treatment, there have, initially when the disease appeared early 2020, nobody knew what was the ideal therapeutic option. They have tried all the available medications, like starting from hydroxychloroquine, interferon, ivermectin, flavipiravir, then remdesivir, etc. But now only few of these are supposed to be helpful in the COVID patients, and most of them have become obsolete. So therapeutic and COVID-19, if you look at the recommendations, are that what I'm trying to tell you is for the steroids, remdesivir, hydroxyquinone, chloroquine, etc. What is the current? The only one word which I can tell is that the systemic steroids are useful in severe and critical patients. The systemic steroids are not recommended in non-severe cases, and Remdesivir should not be used. Only in some cases it can be used. It has not been studied to be very effective. And hydroxychloroquine should not be used in any patient of any severity. Ivermectin also, initially they had a hype of the ivermectin, but now there are no strong evidences to say that ivermectin help, and lopinavir and others are not to be used in COVID-19 of any severity. Now, for the management purpose, we have to stratify the child with the COVID-19. It is classified as mild, moderate, and severe, and few of them classify into a critical variety also, but I have included the critical in this. So mild variety, wherein the sore throat, rhinorrhea, cough, and fast breathing. The moderate illness, the pneumonia, mild to moderate pneumonia, but there is no signs of severe pneumonia. The pneumonia, the respiratory rate is age-based, as we know. Less than 2 months, it is more than 60. 2 to 12 months, 50. 1 to 5 years, 40. And more than 5 years, it is 30. But it is not severe. Whereas the third category, wherein it is a severe category, they have severe pneumonia. They have ARDS, sepsis, multi-organ dysfunction, and cyanosis, pneumonia with the cyanosis, pneumonia with the hypoxia. That means these severe pneumonias classified as severe illness. So asymptomatic children, how to manage? See, most of the cases which we see in our clinical practice are asymptomatic. And moment the report is ready, parents are highly anxious that my child is positive. How should I do? We have to console and convince them that it doesn't need much medicine. And there are no interventions. Isolation from others, but they can be isolated with the parents. So the present recommendation is that isolate with the parents. I will come to that later. And watch for symptoms for the first 10 days. If the child is planning to get any elective surgeries, it has to be delayed. For isolation, what are the guidelines? How can I isolate? Because a lot of questions come when we say that parents, with the parents, it has to be isolated. If the parents are negative, will they not get? If the parents are positive and the child is negative, will it not get? So the current recommendation is that isolation with the parents, even if the parents are asymptomatic. If the parents are positive and child is asymptomatic. But remember that the usual practice of sending to grandmother's house or any other relative's house has to be strongly discouraged. In clear terms, we have to tell them and educate them that not to send the child to any other's place, because this child may be carrying, maybe in the incubation period, though the present test may be negative, and after going there, he becomes positive and he is at a higher risk of transmitting the disease to the others there. So what we have to tell is that a negative PCR doesn't rule out infection. This child may be in the incubation phase. Asymptomatic contacts have to be tested 5 days after exposure. So today there is a exposure history, tomorrow only getting test is of no use, because it needs at least 5 days for the incubation. So test the asymptomatic contact only after 5 days of contact. The third important thing we have to remember is that to document the negativity, it is not required to have a negative PCR, because sometimes even if the viral load has come down, but the PCR can be positive for much longer time. So you have completed 14 days or required period of quarantine and isolation. After that, if the child is stable, there is no need to repeat the PCR. The child has to be isolated 10 days after the symptom free and 20 days after the severe disease. So severe diseases need a longer period of isolation. Now, the mild disease, how do we manage? So mild is influenza-like illness with the respiratory rate, which I have told. He may not have fever or may have fever with some symptoms. and no investigations are needed, no blood test, no chest imaging. So mild diseases, mild symptoms, home isolation, as I have told. Suppose some rare cases, home isolation may not be possible. For example, there is small room, small house with no rooms. There is overcrowding at home, lot of people at home. High risk patient are there at home and inadequate facility to isolate, and monitoring is not possible. Or child is at high risk like immunosuppressed or chronic disease. So those are the children who have to be kept in COVID care center, and they have to be cared in child friendly environment. And in such cases, the parents may be allowed to take care of the children, but they have to use PPE and appropriate precautions, COVID appropriate precautions. The management is just paracetamol, and we have to avoid ibuprofen, mefenamic acid, etc. All NSAID has to be avoided. No cough suppressant, warm goggles in older children, but antibiotics, big no. So none of these medicines have a role in this thing, only in severe cases, but no drug is needed in the mild cases. At home, we have to train the parents for home care. We have to explain to maintain a monitoring chart. Respiratory rate counting has to be taught to them, especially they have to count when the child is not crying. And these are the danger signs which they have to keep looking for: the chest indrawing, nasal flare, cyanosis or the bluish discoloration, cold extremities, reduced urine output. We have to teach them how to monitor the saturation, because in very small babies it's very difficult to monitor at home because the fingers are very small, and how to communicate to the doctor, when to contact the doctor and emergency what to do. Then we have to tell them when to bring to the hospital. If the child develops a breathing difficulty like rapid respiratory rate, chest indrawing, nasal flare, cyanosis, child is inactive, lethargic, poor feeding, altered sensorium, seizures, or the oxygen saturation whenever it is monitored below 94. These are the situations when they have to bring the child to the hospital. So summary of mild illness is: mild illness comes with the sore throat, rhinorrhea, cough, and home isolation and feeding, paracetamol and hydration are the more important. Teach about the danger signs. Now coming to the moderate disease. The fast breathing you have to look at. There is no severe pneumonia. Saturation can be around 94, but more than 90 it should be. It cannot be below 90. And in these cases, we have to admit in dedicated COVID care center, and some basic investigations, ECG, X-ray may be needed. Oxygen may be given if the saturation is below 94 to maintain it above 94. If there is wheezing, inhaled bronchodilator, preferably MDI, than with the spacer, than nebulization, because it is a aerosol generating procedure. Antibiotics, again, big no. But sometimes if you suspect some infections, especially in immune compromised children, depending on the local antibiogram, we may have to give some antibiotics, otherwise no. So these children also, moderate cases, there are no role for any of these drugs. So monitoring, we have to be little more appropriate, like heart rate, BP, respiratory rate, saturation, respiratory rate, then oxygen need, etc. If worsening, then we have to do the tests like CBC, platelet count, absolute lymphocyte count, renal function test and liver function test, then inflammatory markers like CRP, D-dimer or ferritin. Whenever there are danger signs in early phase, we have to send to the higher center. That has to be sensitized to the parents and the peripheral doctors. One is increased workout breathing, hemodynamic instability, and increase in the oxygen requirement. When these are there, it is better to refer to the higher center. So moderate case, when there is fast breathing, pneumonia like illness, monitor only paracetamol, Monitoring is more important. Oxygen may be needed if there is hypoxia. Steroid if there is a rapid progression. Otherwise, no. Some people the advice remdesivir, but the role is controversial, may be given in a sick child. So COVID-19 severe disease. Severe disease is one where there is a severe pneumonia, ARDS, or pneumonia with the cyanosis, hypoxia, increased respiratory effort. And these are the children who need either ICU or HDU, depending on the condition. They have to be completely evaluated for thrombosis, bleeding and clotting factors. Then HLH and organ failure also has to be investigated. Steroids plus or minus remdesivir, empiric antibiotics, oxygen, fluid restriction, and then organ support, all renal replacement therapy, depending on the need and depending on the individual case. And the supplemental oxygen should target more than 94, and nasal prongs or cannula are preferred. If the child is on oxygen with less than 90% saturation with the minimal respiratory effort, then other options like face mask or oxygen hooded flow, then venturi mask or non-rebreathing mask, etc. may be needed. HFNC may be tried in some cases, which is preferably over CPAP if the saturation is not up. Then NIV support is offered only in selected children with the respiratory distress, as the failure rate is very high. These appropriate PEEP, etc. has to be maintained, and closely monitor and intubate if the patient deteriorates or there is no improvement within 1 hour. So this is the usual intensive care management. So I will not be talking much about the intensive care management. So these are the summary of whatever I told: fluid balance, oxygen, respiratory support, circulatory support, etc. So COVID-19 management summary is that basically we have to categorize the child based on symptoms and signs. The management protocol should be according to the severity. Infection control measures in all suspected and confirmed cases. Mild disease, it's home isolation, monitoring, and symptomatic treatment. Moderate, you have to give admit and then oxygen and symptomatic treatment and monitor. Severe, admit in HDU or PICU, oxygen, HFNC, then NIV and mechanical ventilation. Antimicrobials whenever there is necessity, and close monitoring is the most important thing. Now, a brief about the recommendations for care of the newborns. One is we have to know that vertical transmission is very rare. Intrapartum and postnatal transmission occurs commonly, but it is preventable with the simple measures. Most of the infected neonates are asymptomatic, or they have symptoms related to prematurity or other complications. But the studies till now have not shown any congenital anomalies, unlike Zika and other viruses. So COVID-19 pneumonia and other inflammatory syndromes are also reported in neonates, but it's very rare. And effect of COVID-19 in the first trimester is also not well known. But the challenges in these is that the delivery room, how do you handle? Breastfeeding, how do you handle? Immunization, communication, counseling, and if the parents are positive, how do you protect the child from COVID-19? These are the few challenges we have. The other challenge is the mode of delivery. Mode of delivery is the choice of the gynecologist depending on the indication. Resuscitation of the child if needed. The testing the baby we should do at 24 hours or at discharge. Rooming in, if the mother is otherwise fine, she is not sick, you can allow the baby to be with the mother. Feeding, but breastfeeding only has to be given, but respiratory hygiene has to be taken care. Vaccinations has to be given as per the protocol. And then discharge time, you have to counsel the mother regarding the danger signs, and neonatal MIC is another problem. So NRP remains the same. the precautions, we have to take ultimate precautions, especially N95 mask, gowns, and other infection control measures have to be taken whenever there is a delivery going on. The second thing is the area of the care. How do you choose? If the mother is COVID suspect and baby is stable, mother is COVID positive and baby is stable, mother is COVID suspect, baby is sick and less than 34 weeks, and mother is baby is sick and less than 34 weeks. So in these cases, the admission and periodic assessment has to be done, and COVID suspect and a stable neonate and a COVID positive stable neonate. If the mother is sick, room in is no, and they have to be, if mother is not sick, then well baby COVID ward, it has to be shifted, give EBM or formula pills if required. Then COVID suspect neonate with less than 34 weeks gestational age, shift to COVID suspect area. And COVID positive neonate with the gestational age less than 34 weeks, shift to COVID positive area. So this is how the COVID area is chosen depending on the positivity of the baby and condition of the baby and positivity of the mother. Breast milk has to be given, direct breastfeeding, or in some cases, if it is not possible, express breast milk, KMC, and then rooming in with the mother with all due precautions. Mother has to be taught about the proper hand hygiene and respiratory hygienes. And while if at all you are giving EBM, you have to take proper care to avoid contamination. This is how the postnatal care is there. The baby and mother are kept in separate room, separate isolation room, and hand hygiene has to be there before breastfeeding. If it is direct breastfeeding, and then if it is express breast milk, we have to take ultimate care. Then lactation counseling, etc. has to be done, and the routine physical examination and monitoring has to be done under strict infection control. Immunization has to be followed as per the schedule. The discharge mother and baby at the earliest once the conditions are stable. Baby should not be handled by multiple people. Correct masking and hand hygiene has to be taught to them, and standard care has to be taught to them. So minimum handlers, masking, physical distancing, respiratory etiquette, hand hygiene, housekeeping tips. These are the things that we have to teach them. Now a short thing about the MISC, and it is one of the other manifestations which we commonly see in these cases. And usually, as you know, the first it is reported in the UK following a few weeks of COVID positivity. Then it is found to be occurring across the globe. The surge in COVID-19 is followed by a surge in the MISC. And less than 1% of the COVID-19 children it is found. And less than 10% of the children hospitalized are related to this condition. And a few of the institutions have reported a higher number of cases even in this pandemic. So WHO criteria for MISC is children and adolescents of 0 to 19 years with fever of more than 3 days. And any of the two following should be there. One is rash or bilateral non-purulent conjunctivitis or mucocutaneous inflammatory signs, oral, hands or feet. Child is in hypotension or shock, myocardial dysfunction features, pericarditis, valvulitis, and coronary abnormalities, either by echo or elevated markers like troponin or NT-proBNP. Coagulopathy evidences, PT, APTT, elevated D dimers, and gastrointestinal problem. And there should be elevated markers like ESR, CRP, and procal. No other cause of inflammation like bacterial sepsis, Staphylo or streptococcal shock syndromes, and evidence of COVID-19 either by RT-PCR or antigen or serology, or there is a likely contact with the COVID-19. So this is the WHO criteria for diagnosing MISC. Various symptoms may be there, fever, and this is the percentage of symptoms which I've told. They can even have swelling of the hands and feet, lymphadenopathy, myocardial involvement, respiratory involvement, shock, liver involvement, cirrhosis, neurological involvement may be there. And this is the pathophysiology wherein in a severe MISC, the inflammatory response, because it's a immune mediated, the IL-6 and chemokines are quite high. You can see in a mild disease, it is quite less. And in a severe case, these IL-6 and chemokines are quite high and quite more prolonged. And that is responsible for most of the ill effects of MIS. So this can be classified into three. One is COVID-19 acute infection with asymptomatic, wherein we give symptomatic treatment only. Multi-system inflammatory syndrome, which occurs 2 to 4 weeks after the COVID-19. And whenever there is a red flag sign like high fever, vomiting, pain, abdomen, etc. COVID-19 associated febrile inflammatory state, the markers may be elevated, but signs of multi-system involvement are not there in this. Whereas the toxic shock syndrome like symptoms may be there, MISC. There is one more wherein hyperimmune phase during COVID, that is moderate to severe patients with the immunomodulator and anti-inflammatory drugs can be given. So that is the third phase. But most MISC which we see belongs to this group, wherein they can be Kawasaki-like or febrile inflammatory state-like or toxic shock syndrome-like. And these Kawasaki-like disease may not come with the shock or maybe with the shock. If they come with without coronary dilatation and no shock, IVIG, aspirin can be given. IVIG is given 2 gram per kg over 12 to 24 hours. Aspirin about 12.5 milligram per kg per dose 4 times. That is around 50 milligram per kg per day in 4 divided dose. If they come with the shock, in addition to that, you can use methylprednisolone 2 milligram per kg up to 10 milligram per kg. Whereas the toxic shock syndrome, like if they come with the vasoplegic shock, we have to treat the shock, vasopressors, IVIG, etc. If there is a left ventricular dysfunction, then we have to start with the dobutamine or milrinone and respiratory support and IVIG, methylprednisolone, and low molecular weight heparin also has to be given. In IVIG and steroid resistant disease, anakinra, tocilizumab or infliximab may be given. So evaluation is if there is unremitting fever, epidemiological link and the clinical features of suggestive of MIS is there, and there is no alternative etiology, then tier 1 and tier 2 tests have to be done. Whereas if these are not there, you should evaluate according to looking at the alternative diagnosis. But you have to monitor the features of MIS. And shock-like symptoms are not there, tier 1 evaluation. If that is positive, then only you go for tier 2 evaluation. The Kawasaki versus MISC, if you look at, there are very difficult to differentiate, but some of the features may help us to differentiate. Kawasaki occurs more in the younger age group, that is 6 months to 5 years, whereas MISC occurs in the older age group. The total count is high, platelet is high in Kawasaki, whereas it is platelets are normal or low. Atypical Kawasaki occurs in 1/3, whereas in MISC it is about 50%. Gastrointestinal involvement, respiratory involvement, CNS involvement is not very common in KD, but in MISC it is very common. Echo abnormalities mostly seen as the coronary artery abnormalities in KD, whereas in MISC it is myocardial disease is more. Macrophage activation syndrome, low risk in KD, whereas high risk in MISC. Kawasaki disease, shock-like syndrome, 2 to 7%. But here presenting a shock is 57%, quite high. The tier 1 evaluation is CBC and renal function, metabolic function, CRP, and SARS-CoV-2 serology or PCR. The positive screening of both means a CRP of more than 5 or ESR of more than 40, ALC less than 1000, platelet less than 1.5, sodium less than 135, neutrophilia or hypoalbuminemia. Whereas the tier 2, you have to do a cardiac monitoring, ECG, echo, BNP, troponin. Then inflammatory markers, which I have already told, have to be done. Then blood smear. So shock-like syndrome, missy with the shock-like life-threatening disease, steroid 2 milligram per kg with the IVIG. Whereas not immediately life-threatening, you give steroids first line or IVIG as per the availability. And antiplatelets and anticoagulants, aspirin and enoxaparin can be given, especially when there is a coronary aneurysm with the Z score of more than 10, thrombosis or left ventricular ejection fraction is less than 35. Aspirin has to be given in almost all the patients. And not responding, you repeat the IVIG and high dose steroids, pulse methylprednisolone, 10 to 30 milligram per kg for 5 days can be given. The cardiac specific recommendation, ECG, echo have to be repeated, especially the echo after 1 to 2 weeks and then 4 to 6 weeks, and repeat after 1 year. Cardiac MRI, cardiac CT can be done depending on the need. The discharge criteria depends on the clinical, laboratory, echo, and other conditions. And you have to advise the tapering dose of steroids, the aspirin, how long to continue, and low molecular weight heparin to be continued for 2 weeks after the normal echo. Now, about the third wave, which is supposed to come, IAP has come out with some statement about the third wave. What is the possibility of third wave in the coming months? What the IAP viewpoint is that third wave might come, but it is not that it will target only children. It will target all the people who are susceptible. And children are likely to suffer even otherwise. And it is not that they are not expecting a huge surge in pediatric cases, but we have to be prepared for that, because these are the predictions based on mathematical models, and it may be proper, but in anticipation, we have to prepare both intensive care, pediatric care fully, because suddenly if the surge occurs and more number of pediatric patients come, then we have to be able to handle it in the right vaccines. We know that pediatric vaccines have not yet come. 12 to 18 years they have started giving, but in India, the Bharat Biotech is doing the trial for 2 to 18 years. And only after proper clinical trial and proper evidences, then we may be able to give the vaccine. So the prevention, we have to take care of the SMS, the sanitization, masking, and social distance. Masking below 2 years may not be very feasible, not required also. WHO says up to 5 years. But as a general rule, 2 to 5 years, if they are ready, you can use. But after 12 years, it is like adult. So teach the parents about SMS, social distancing, masking, and sanitization. To summarize, with the surge, more children are affected. Profile of illness has not changed over a period of time. RT-PCR, CBNAT, RAT has to be done on the respiratory specimen. We have to categorize the children based on the severity, which helps for management. Management is mainly supportive. Most of the children can be managed at home, especially those who are asymptomatic and mild symptomatic. Isolation has to be with the parents, and moderate and severe has to be managed in the inpatient facility. Medications we have to rationally use. MIS-C is seen but not very common, but we have to do early diagnosis so that we don't miss it. We don't miss the MIS-C, but we have to do early diagnosis and treat so that child will not develop any complication. Trials of vaccines in children are underway, but once it effective and proven safety vaccine comes, then probably we have to use it to prevent the child from getting well. Thank you very much. What clinical and biochemical parameters are different in children compared to adults? So basically, there are not much of difference, but we don't do these parameters on a regular basis compared to adults. And we do it only when there are certain high risk conditions, only in severe cases. But overall, the biochemistry parameters are similar. But what is found is that the amount and degree and of all the biochemical parameter abnormalities is less in children compared to the adults. The second thing is clinical parameters. Clinical parameters, as we told in children, I have already told that the most of them are asymptomatic, and mostly it so happens that the fever doesn't go many days, 1 or 2 days, except in few children. They may come with even gastrointestinal symptoms, loose motions, vomiting. They may come with the dermatological symptoms, and there are few cases of neurological presenting as neurological manifestation, and dermatological manifestation is also there. Do children have more immunity against viral infection, coronavirus infection, compared to adults? Yeah, probably yes. That is because there are various other coronaviruses which child might have experienced. As I told, children suffer less with the coronavirus infections. One reason, probably the previous repeated infections due to other corona-related viruses. Coronaviruses has a huge family. SARS-CoV-2 is what we are seeing, but other coronaviruses might be cross-protecting about these children. The third question is incidence of multi-system involvement in post-COVID. Yes, it is definitely causally related to the COVID. Many of us have seen a lot of cases. In a tertiary care center, we have seen at least 10 to 15 in the last 6 months, because it is more of a referred thing. But definitely about 1 to 5% of the total COVID positive children, after a few weeks, they develop MIS. Mortality rate of children with COVID in India. See, as a rule, mortality is very less in children. The mortality of adults may be 4 to 5%, but in children it is less than 1%. It is about 0.3%, 0.1 to 0.3. One more question: role of methylene blue in COVID, pediatric COVID. Especially in adults now with the mucormycosis upsurge, there has been talk about methylene blue, but that has not been tried or proven in pediatrics. COVID-19 vaccine for children, how safe, how efficient, when to give? So definitely the COVID-19 vaccine will be safe, and of course adequate safety, efficacy studies, safety studies, immunogenicity studies, all this has to be done. The adult COVID vaccine came with a very fast this thing. That means within, the normal vaccine development takes about 10 to 15 years. But The COVID vaccine came to the market within 10 to 15 months. So that is the difference between these two vaccines. But in adults, it's okay. But in children, we need to do very thorough clinical trials. We have to prove the safety, we prove the efficacy, and then only it has to come to market. So when to give is whenever it is available, because now they are doing a trial from 6 months onwards also. So any child, if it is found to safe and the clinical trials show the safety, then probably yes, give. Choice of antibiotic in children. There is absolutely no role for routine use of antibiotics in children with COVID. Adults, you know that azithromycin, initially they thought it acts as an antiviral, so they started giving azithromycin, but definitely, absolutely, there is no role. Doxycycline was given, there is no role. All these have been disproved. So now there is, especially in pediatric practice, there is no role for antibiotics, even in a severe case. Only when there is a evidence of bacterial sepsis or bacterial infection, we have to give. MIC in neonate, yes, few of the neonatologists have reported the MIC like syndromes, and they have improved with the IVIG, etc. But I personally don't have any experience with the MIC in neonates, but I have interacted with people who have treated. What vaccine is safe for pediatrics about 10 years? Do we see lung involvement in bad as adults in pediatric population? See, the first question is which vaccine is safe for children about 10 years? See, once the studies are proven, see now the Pfizer vaccine is being given. So similarly, our Covaxin or Covishield, once the studies are there, if they are proved safe, absolutely there is no difference between the vaccines, but you can give whichever is available, whichever is proved safe, whichever has been studied well once it comes to the market. At present, it is difficult to tell. And lung involvement, of course, is not as bad as what is seen in adults. Pediatrics, X-rays are not, unless in a severe case, X-rays are not useful. The CTs may be useful, but the CT involvement, pulmonary involvement in children is very uncommon. In severe cases, we have seen few, but it is not to the extent what we see in adults. D-dimer in children. See, doing a routine D-dimer in children with COVID is of no use. In fact, D-dimer can be elevated in any of the other severe infections also. It is not specific for COVID, but it only in severe cases, when it is high, then probably. But doing a routine D-dimer in mild and moderate cases is of no use, only in severe cases. How long inflammatory markers to be monitored? See, once the clinical improvement occurs, and once the inflammatory markers, when you do at recovery or discharge, it is normal, then probably there is no need. Only an occasional patient who has high markers or a patient whose symptoms are not responding, taking longer time, you may need frequent monitoring. Otherwise, once the child clinically improves and the initial markers show a decreasing trend, probably there is no need. Mild, what we have to do in children with mild symptoms, but with the high D-dimers. See, in those children, this is one important clinical situation which we have often seen. If the child is otherwise symptomatically better and other parameters like ferritin, LDH, CRP are not very high, we have to just monitor. If the symptoms are normal, symptoms are mild, you need not be very aggressive in treating this care, but this has to be monitored. Only when it is worsening, then we may have to treat, otherwise, no. Some of my cases which I have seen, they have improved on their own. And when we keep on doing the monitoring, it has come down. 6 months old infant, 2 days fever, shock like syndrome, high volume replacement, blood culture isolated, staph aureus, CB net positive. Kindly comment about the combination. See, there are two possibilities here. One is COVID with the MIC-like syndrome. The other one is staph aureus sepsis. So when there is a blood culture grown staph aureus sepsis, which probably MRSA, which I suppose you have not given whether it is MSSA or MRSA, whatever it is, you have to treat it as a infection only. And meantime, the shock has to be treated, whether it is due to staph aureus or this thing. Whatever you have done is absolutely right, because culture, when it shows, you have to give the appropriate antibiotic. And in the epidemiological background of COVID and COVID positivity, you cannot neglect MIS-C-like syndrome. So both have to be treated, and you have done a right thing. Incidence of COVID positivity after normal delivery or LSCs in India, it is, I don't have any statistics, but most of the mothers may be positive, but the children, the babies to be positive, it takes some time. So such babies, we have to do the RT-PCR at birth and before discharge, and then we have to tell them to get it frequent follow-ups, so that sometimes after the incubation period, baby may be positive. There may be somebody who is at home who may be positive, or the mother may be asymptomatic carrier, she may be giving. So with that, but exact incidence is not known. I think that completes the questions. Thank you very much for the patient listening and the good interaction.